Thank you, Chris, for that very kind introduction. And thank you all for hanging in there as one of the last panels of the conference. We are having a panel on burnout. The irony hasn't been lost on me, and I hope all of you, of having the burnout panel as the last panel. But we are nearing the end of an incredibly rich and nuanced conversation on the role of artificial intelligence in healthcare, from drug discovery to healthcare delivery. You know, as one of the last panels, we do risk the peril of replicating or treading old ground that we've discussed over the course of the conference so far, but we're really going to try to take a unique and different perspective on the discussion on artificial intelligence during the course of this next 40 minutes. And really what we want to focus on is AI as a tool in workflow. Specifically, how can artificial intelligence bring back trust, joy, and humanity into the delivery of healthcare? And so why do these three things? Why trust, joy, and humanity? And many of you know we have many epidemics in healthcare, but one that is of crucial interest and concern to all of us here at Partners Healthcare and throughout the country is clinician burnout. And so I just want to share with you some facts, some that you know and some that might be new to you about clinician burnout in America. So there was a recent study over 2011 to 2014 that found 50% of clinicians said they were burnt out, tired, did not have what it took to complete their job. And that had risen 10% during that time, whereas when they looked at other industries, it was flat. So high rates of burnout and rising faster among clinicians than non-clinicians. And burnout is independently correlated with increased medical errors, malpractice suits, turnover, referrals, and test ordering, driving healthcare costs, decreased patient satisfaction. One of our colleagues in another health system did an analysis of what does turnover cost their organization when a clinician leaves the system, and it costs the system anywhere between $500,000 to $1 million for the recruiting fees, as well as the lost productivity for that health system. Clinicians have 25% higher alcohol abuse, 200% higher suicidal ideation. And one of the most shocking figures to me was that in the last year, nearly 400 clinicians had committed suicide, nearly one a day. These are startling facts, but I do see light ahead, and I think many do see light ahead. The first step to tackling this problem is recognition. Partners Healthcare, under leadership of Dr. Torchiana, has recognized this as a problem, and has committed significant resources to addressing the physical and mental health of our workforce. In addition, the research community at large across the country have started to focus attention on what could be actionable solutions. How do we frame this problem, and what are the actionable solutions for us to address the burnout problem? And I'm quite fond of Steve Swenson's work. He was recently at Mayo and moved to Intermountain Healthcare, and he shared a framework of how to think about what do we need to do to address burnout, clinician burnout. And he had three simple phrases, each with very complex solutions behind them, but I wanted to share them with you. The first is to satisfy social and psychological needs. The second is to strengthen resilience. The third is to eliminate structural and functional drivers of burnout. And it's that third one, the structural and functional drivers of burnout, where I think our panel is going to really explore how could artificial intelligence play a role in tackling burnout. So with that, I'm just going to turn it over to the panel. And Peter, if you could just start telling a little bit about your background and what your organization's doing in artificial intelligence.
Sure. Thanks, Sree, and hi, everybody. So my name is Pete Durlach. I run strategy and new business development at Nuance here in the Boston area, so heavily involved in a lot of things, including a lot of our AI efforts. And it was really struck me the other day with Dr. Gawande with his presentation talking about, it's not just about the technology, it's about getting it into the workflow and making it usable by physicians. And that's something I think often gets overlooked by technology players in a lot of ways. You actually could see from the early look discussion the other day some great interventions. But the question that always pops into my head is, okay, so how are you going to actually get them into production at scale? And that goes to the physician burnout issue, because a lot of what happens is technology gets developed and then it's interjected in such a clumsy way that the docs and the nurse, they just don't have time for it. They barely have time to get through their day. So anything that adds more work to that, they're not going to adopt. So for us, we really focus on this idea of the last mile and how to try to make things easier. And so a couple of examples from the Nuance side. Again, it's kind of an interesting thing to hear about AI and all the buzz nowadays, but we happen to be lucky enough and privileged enough to be in this kind of core business, and we have some solutions today that have used deep learning for many years. You as partners are a big client of ours around products like Dragon that make a huge difference today. It's amazing actually to see the visceral reaction of physicians when they actually get time back to spend with the patient. That's really the overwhelming thing that we see. As most of you know, somewhere between 30 and 45% of a physician's day is spent on non-caregiving activities around administrative functions. And we have, not just us, but others too, have solutions that can reduce that by an hour or two of day that allows the physician to spend more time with the patient, go home and see their family, or as many of you know who are physicians, not have epic time or pajama time at night when you're dictating your notes. So for us, that's really a visceral thing that we feel. And so the AI is actually real today in healthcare in this problem. I think it's at the very early stages in terms of what we can do. The second piece that we see coming that's been talked a lot about is this move from sort of the dictation use of AI into more decision support and clinical guidance. So again, today in the market, there are solutions that as the physician is documenting, we use and others use AI to look at the whole clinical encounter, deep learning, and provide real-time feedback as the physician is dictating inside Epic, inside Cerner, inside Meditech, inside Athena, and all the other EHRs. And again, if that's done well, it's the value on the physician side is very much the same thing, which is if they can be done with the encounter and deal with the administrative stuff in workflow, they save a lot of time and get less frustrated than after the fact, someone prompting them to code better, improve the documentation better, extract some quality notes. So this idea of first time right, most physicians don't have any extra time. So the idea of doing things later when they have to go back to the chart is extremely frustrating and destructive for their time. So if you can get that stuff out of the way and allow the physician to, what we say, turn the chair around as opposed to facing the computer, face the physician. And the holy grail for this, I know a number of the other folks on this panel are very familiar with this idea, is at some point in the future, physicians are going to walk into a room, a patient room, have a conversation with the patient, looking at the patient, and AI is going to produce the draft document and extracted facts automatically. Likely there's going to be a human element in the middle of that for a period of time, whether it's a scribe or virtual scribe. But at the end of the day, the goal is to let the physician in workflow have the conversation with the patient, and out of that stream, extract the data that's required to document the encounter, code the encounter, and extract quality measures. So their focus is on the patient. And much like John mentioned from IBM, we have data that when the physician is spending more time with the patient, this is no shock. Their satisfaction goes up and the patient satisfaction goes way up. So we know that that's the right answer, and so we're trying our best on that path to try to get there.
Thanks, Peter. And Dennis, I was wondering if you could just share with the audience a little bit about your background and the work that you're doing in artificial intelligence.
Sure, I'm Dennis Schmuland, Chief Health Strategy Officer for the U.S. Health and Life Sciences, and for the U.S. we have a pretty audacious mission, and that is to empower our customers and our partners to make health and care personal, effective, and affordable, because really it's none of those three today. And we have a pretty audacious, or really a clear strategy to achieve that, and that is to hold ourselves and our partners accountable to bring intelligent solutions to market that really advance the quadruple aim. And the quadruple aim we set our sights on because we think the quadruple aim really defines value in value-based care. Better health, better experience and outcomes of care, lower cost per capita, and increasing the productivity and work experience of the providers. And fundamentally, our core business is really to provide the compliant building blocks for developers, which may be academics, and may be partners, may be customers, to bring to market those intelligent solutions that are flexible and affordable and work alongside the electronic health records of today. There are three platforms or building blocks that we have today that almost 1 million developers are using. One is cognitive services, which includes vision, knowledge, language search, and thinking of the other one here. Speech, of course, speech. The second is Azure Bot Services, and that enables our developers to put together natural conversations and interactions with consumers, as well as patients and even physicians. And the third is machine learning and deep learning services. But we're also infusing AI into some of the products that millions of people are using, including physicians day by day, to really make what we like to say AI everywhere, every day, for everyone. And so we're building and fusing AI into things like Outlook and Office 365 and Dynamics 365 and Cortana and Bing, for example. Thanks.
Thanks, Dennis. And Punit, if you could just share with the audience a little bit about your background and what your organization is doing in AI.
Sure. My name is Punit Soni. I probably have the briefest experience with healthcare in this panel and probably in this room also. My background is I used to run the mobile apps group at Google, and when we acquired Motorola, I was running software for Motorola, and in my career have built a lot of consumer and gaming and a bunch of mobile related things. So very deep consumer experience. I wanted to start a company. I wanted to start it in healthcare. As with most industries, especially healthcare, where there is a lot of seemingly significant monolithic software stacks that are relatively custom implementations, it felt like the right equation would be to find a powerful constituency that has a deep burnout problem, the solution of which aligns with a trend that's incoming. The powerful constituency is physicians. The burnout problem is pretty real. You guys are all intimately aware of it. And the trend is, in my opinion, the increased commoditization of voice stack. You know, you obviously referred to that, and machine learning. And so, you know, as an outsider, you know, I actually had the privilege to spend a chunk of time in partners in a few places shadowing doctors. And what I saw, you know, was what was happening with doctors. It felt like as if, you know, I was asking my VP of engineering that for every line of code that was written, he has to write a line of comment. And I will pay him based on the number of comments that were written. And I will, you know, if the product fails, that I'll sue you. So it felt like an incredibly difficult situation in which we have put these incredibly sophisticated people. So what Robin is doing is basically building a digital assistant for doctors. It uses voice, clever uses of basic machine learning models, doctor-patient interaction, and figures out how to take that interaction and create a clinically comprehensive note out of it. The problem, in my opinion, of artificial intelligence is not the how do we create seemingly new and innovative models, language, speech, AI, et cetera, to actually run this. It's a problem of data. And so if you can solve a problem that's fundamental to a powerful constituency, that can potentially be used for them almost as an entry point to creating all data, then you can use that data and actually build on top of it and solve a lot of more complex problems. So that's what we're doing. We're basically building a front end for the doctor that they can use to collect information and create documentation. And we do it in a structured format so that over time we can use that and feed it into awesome ML models that Microsoft and Google and others are building to figure out more interesting, nuanced benefits from it.
Great. Thank you so much for sharing that, Punit. And David, last but not least, if you could just share a little bit about your background. And in addition, David's role is to make you'll hear about his background, but one of the projects that you're working on is Project Kitty Hawk, which is specifically address clinician burnout at Mass General Physicians Organization. So I was wondering if you could also just talk about specifically the Project Kitty Hawk effort.
Thanks so much, Sree. So I am the Chief Medical Information Officer for the Massachusetts General Hospital's Physicians Organization. I'm dual trained and certified in internal medicine and pediatrics, and I still practice primary care, seeing adults and kids in the office. So I'm one of the frontline docs that's experiencing the administrative burden that is burning out my colleagues. And so my team, as Sree is talking about, our heart is in taking care of patients. Our passion and mission is in reducing the administrative burden that causes clinician burnout and returning our doctors to the joy of practicing medicine. So let me tell you a little bit of a story of where this comes from. As Sree pointed out, and Dennis Pete, Punit also, half of our physicians in this country are by some measure burned out. When we've surveyed our own physicians at Massachusetts General Hospital, it's up to 46% of our physicians experience some kind of burnout. And in some of the departments, it's as high as 80%. So we've surveyed our physicians and gone even deeper and asked them, well, what is causing the burnout? And they indicate it's the administrative burden associated with taking care of our patients. And when we drill down a little deeper, they say specifically it's things like working in the ambulatory EHR, doing electronic prescribing, working in medication reconciliation, prior authorizations, charge capture, communicating with patients and colleagues, working in the in-basket or the communications module. Now, each of those things, our doctors would say they're essential and important things that are done in healthcare. Everyone has to do it for the safety and quality of our patient care. But you add it all together in aggregate, and it leads to the burnout. So what's going on there? I would submit that if you look at the root cause of the clinician burnout, of the administrative burden, it comes down to what is healthcare all about. In this room, I think we'd all agree that healthcare, in many ways, as much as it's a human endeavor and it's about the human relationship, it's also the journey of data. It's data as it's captured, as it's analyzed, as it's interpreted, visualized, and then executed upon. But if we focus only on individual parts of that journey and fail to look at the whole picture, we end up with burned out people. So a few years ago, actually, Dr. Torchiana, who at the time was the CEO for the MGPO, came to me and he said, David, you're the CMIO. And in many ways, as the liaison between our 2,000 doctors, 200 practices, and IT, you are responsible for the technology that's caused the burnout, that is causing our physicians to feel like they just can't handle anymore. So you go back, find a team, and do whatever it takes by technology or process to solve the problem. And so we created at Mass General a team that we call the Kitty Hawk Portfolio. Really, it's multiple teams that are working currently on about 25 different projects to look at solving the problem of administrative burden and returning our physicians to the joy of practice. So why Kitty Hawk and what is it doing? So we named it very intentionally. We were looking at the Wright brothers as a model for solving a problem that people thought was unsolvable. But there's also some neat analogy to the aviation industry, and some of the speakers at this forum have brought this up. If you look at aviation, they are also talking about a very high-risk environment where even small mistakes can lead to people dying. Secondly, it's an industry that brings in new technologies constantly, and people and processes and workflows need to morph in order to address the changes in technology in real time. So you look, for instance, at fighter jets, and you might wonder, how come some fighter jets have 2 crew members, some of them only have 1? Well, if you look at the evolution of fighter jets in the Korean War era with the 2nd generation jet fighters, most of them had 1 pilot in the cockpit. And the reason is that the equipment, the weapon systems were fairly rudimentary, and you could get by with 1 pilot in the cockpit. And in fact, that was probably the most efficient way of dogfighting in that era. But then we got into the Vietnam era, and we started seeing 2nd, 3rd, and the early 4th generation fighters. And now you start to see the radar systems, the weapon systems, the missiles, the heat-seeking missiles, the anti-aircraft systems got too complex for 1 human being in the cockpit to deal with. So they added what in some services is called the radar intercept officer or the weapons system officer to assist the pilot in flying the plane. Interestingly, you look at the current 5th generation fighters, the F-35, the F-22, they're back to 1 pilot. How did they get around that? Now they've brought in AI to assist the pilot in doing all the complicated tasks of fighting and prosecuting what their mission is. Notice that there's a real analogy here to healthcare. If we go back even 100 years, essentially the process of diagnosis and treatment came down to data gathering, and the data gathering was the physical exam. Then we added some tools. We added a stethoscope, so now you can gather a little bit more data. Then we added x-rays. You can now see into the body and get yet more data. But then the exponential increase in that data gathering happened over the past 50, 25 years or so. CT scans, MRIs, functional MRIs, the whole imaging suite, the analytics that now come along with population health, the screening tools. Now our physicians are sitting in front of 27-inch monitors that look a lot like air traffic control maps. And what has happened is the management and the regulations around managing data have outstripped individual humans' capacity to deal with that data. And that's leading to the burnout. And so in Project Kitty Hawk, what we've done is we've tried to address each of those areas, looking at the entire arc of the journey of data, to look at ways that we can help relieve the physician and also set up helps for the physician, an assistant like the Rio in a jet fighter, to bring the physician back to focusing one-on-one with the patient and not on the 27-inch monitor. So let me give you a few examples of what we've done, and I think you'll find that it really ties into what my colleagues on the panel have been working on as well. So one of the things that we recognize is that we needed to supply our physicians with adequate tools that really meet up with the demands of clinical documentation. So we implemented computerized voice recognition. And as Peter said, computer voice recognition is much more than simply replacing dictation or replacing a stenographer with computer voice. It actually starts to move into using voice commands so that you can speak to the computer and have it do work for you. So that's a pretty embryonic go at bringing an assistant to our physicians. The next thing that we've done in the Kitty Hawk portfolio is try to delegate and centralize work like medication renewals, work like abstracting data, bringing in data from patients, from referring physicians to prep the chart so that when our physicians open up our EHR for the first visit, they're not seeing a blank glass, but they're rather seeing data that are now entered into a usable form. So that's one piece of work. Another evolution has been the implementation of scribes and virtual scribes. What are we doing there? So we're recognizing that our physicians tell us so much of their effort is focused on documentation that they're unable to focus on the patient interaction. So in about 120 of our physician practices, we've implemented live scribes that are people that follow them around in the exam room scribing what they're doing. It's just like the medieval times. But also for about 175, going on 200 of our physicians, we've implemented virtual scribes, where that scribe that is doing the documentation of our physician is now off-site. Where are we headed with that? Actually, we know that while our physicians who are experiencing voice recognition scribes and virtual scribes are experiencing a tremendous decrease in their administrative burden, that model overall is not sustainable from a cost perspective. Why? Because we're still leveraging human-powered teams. It's the same reason that in the Air Force, they've gone from 2 pilots down to 1 pilot as much as they can. So where's the next step? What we want to do is take the models that we've developed using human-driven teams, human centralized teams, human scribes, virtual scribes, now bring in the AI. So one example is I mentioned that charge capture is one of the burdens that our physicians experience. At Mass General, we've been working with our own data scientists as well as scientists coming from local universities to build a machine learning model that now reads the documentation produced by our scribes, virtual scribes, and the physicians themselves, and actually generate the appropriate billing codes. So for over a dozen of our practices at Mass General, the physicians don't touch the charge capture module. So now we've removed that area of burden for them. As we move forward, what our goal is to take these processes I'm describing and many others and now move them to machine and robotic solutions. That's where we'd love to partner with folks, as you see on the panel. And also that's where, speaking to the 1,600 of you in the room, we're asking for your help because we want to partner with you in moving from the human through to a human AI hybrid model to a pure AI model. And that's where we're going to return our physicians to a way of practicing medicine that brings them joy, that increases patient access and is more cost effective.
Thank you, David. That's a great overview of Project Kitty Hawk. As a clinician on the recipient end, it has improved my own personal workflow, so thank you for all the work that you're doing. And I want to open it up to the rest of the members of the panel. As you heard David describe the challenges that Project Kitty Hawk is trying to tackle, it is more than just the documentation issue. It's about medication reconciliation, which is confirming that the medications that the patient has from one facility is the same as what we have in our own record. It's about prior authorization, making sure that the documentation justifies the procedure or the medication or therapeutic. It's about improving the communication with patients. So it's a very broad remit that Project Kitty Hawk has. So I was wondering if I could just open up to you all about how you all are thinking about your company's positioning to handle the broad range of topics that Project Kitty Hawk and the physician community at large is trying to tackle.
Yeah, so and I have the luxury of having known David for a long time, and so I think again, trying to give you some perspectives from Nuance without being too, nuance-centric from my perspective. I mean, the group here is really advanced in thinking about this problem statement. I mean, everyone has the same problem that Partners has across the industry. I mean, this burnout problem and the set of issues that David highlighted is there. I think it is important that the level of complexity in solving them is a broad range. I mean, as you know, part of the medication reconciliation isn't just an AI problem. It's communicating across what's been done. So these things have to be mapped out in different ways from complexity. But there's a lot of progress. I mean, as Punit mentioned, just to use another example, as many of you, I'm sure, all have an Echo or Dot at home with an Alexa, there's a tremendous need for virtual assistants in healthcare, but none of the consumer stuff are really geared around that beyond the HIPAA support and some of the more simple stuff. They're not robust enough for physicians to use because they're not accurate enough for any of those who've used them at home. So we actually have launched next generation AI virtual agent that's integrated to Epic and other EHRs coming that allow that next level of interaction where you don't have to hold anything. There's an advanced device on the wall. You walk into the exam room and you start talking to the thing in more sophisticated ways, like send a follow-up note to so-and-so, do this, et cetera. But it's still directed. You still have to have the physician do something to do this. But that's the next step in kind of automating some of this function, because for the physicians in the room, I think this is all obvious, but for those that are not, the amount of clicks that physicians have to use, unless you actually are a doc or you've actually shadowed them, you really have no idea how these things, so even saving 5 to 10 clicks per encounter adds up tremendously, and the ability to automate some of that inside the EHRs is just a massive, and it's with technology that's mature today. I think going in the future, one of the big innovations will be beyond more of the have a conversation and have everything magically happening, is this idea to inject intelligence into the workflow that's a meaningful thing. Because the technology is good enough in a lot of cases where you can actually look at the clinical encounter, and if it's an inpatient, I'll give you just an example. We have a solution, as do some others, where we can look at the entire inpatient stay, multiple day, multiple notes across multiple physicians that have both structured and unstructured data, and in real time, look at that information, use deep learning to extract structured data, and provide real-time guidance right in the native workflow of Epic and Cerner. That generates significant reductions in physician time over the week and can also drive up the appropriate reimbursement and quality across that encounter for a significant set of patients. So I'm pretty optimistic about the technology. I think, again, the challenge that we see at Nuance beyond some of the more complex cases, which are very difficult, is it's all about how do you get in the workflow. If you saw, again, I was taken by the first look, which I happened to be a judge for, just the innovation from those 19 folks. Imagine what's going on in the rest of Partners and the rest of healthcare. There's thousands of examples like that of people doing really important work on AI, but how do you actually get that into the workflow that physicians are going to adopt at scale? And I actually think that's a huge problem. A thing that we've been doing, and then I'll turn it over with our partners here in at MGH and partners in the American College of Radiology is the same issue in radiology. You have this explosion of people building image classification algorithms for detecting nodules and diseases in images, but the vast majority have no ability to get that into the workflow of the radiologist. So what we've done by partnering with Dr. Brink and the team here at Partners in the American College of Radiology is build a system where any developer with a single click, whether they're using TensorFlow or the Microsoft tools or NVIDIA, publish algorithms up to the cloud, and then any user of our product called PowerScribe, which is used by about 70% of all radiologists, can single click subscribe to those algorithms, and in workflow, without going to a different system, without getting any change, those algorithms can either prioritize the workflow of what studies to look at based on acuity, or pre-fill out the reports automatically based on best practices. So this is coming really, really fast, and I think there's just a huge opportunity, but you've got to figure out a way not just to build the algorithm, but how do you actually deploy these things that they're going to be adopted? And that's what the thing with Dr. Gawande really hit me. That focus on the process change and how it gets in the workflow is the make or break issue on most of these technologies. It's not the algorithm, in my opinion.
Yeah, I think we have to think about AI in terms of addressing the practice of medicine today and the pains that exist today, but we also think about the practice of medicine in the future and how AI can really help us redesign end-to-end the business and clinical processes and thinking about tomorrow and deliver quadruple aim results in the process. And I've got a story to tell that really illustrates that, and I think really does at the same time improve the productivity and experience of the clinician in primary care. For example, Cox Healthcare, for example, is a health system in Missouri, has about 80 clinics, 1,000 licensed beds, and about 10,000 employees. And what they did is they redesigned from end to end the business and clinical process of diabetic retinal screening. And so they moved diabetic retinal screening to the point of primary care by using high definition cameras in the practice. And so when, as you know, there are about 18 million patients with diabetes today that are at risk for blindness. We can actually prevent blindness in 95% of them, but only about 50 to 55% actually get that retinal screening exam done every year because of barriers of access, inconvenience, and cost. And so they redesigned this process in a way that took away those barriers. So when a patient arrives to see their doctor, they get their vital signs, and if they're due for a retinal exam, they get the retinal exam. The high definition camera takes about 5 minutes. It captures the image. Machine learning algorithms are applied to call out areas of concern. And even while that patient is there, if there is an alert that indicates a high risk, that patient can be immediately sent to a retinal specialist for treatment. But that whole process can be done without the intervention of the physician. An administrative assistant can do the exam. And it really delivers quadruple aim results. You can increase your screening rates from 50 to 55% up to the 90s now. So if we extrapolate that, we're certainly going to improve the population, the health of the population. We could probably reduce blindness in 2 to 3 million patients per year. We can certainly improve the experience and of care because we've removed those barriers of inconvenience, access, and cost. But we've also have a chance to reduce the per capita cost of care because annually the treatment for retinopathy runs about $5 billion a year, and it's estimated to go up to about $20 billion in the next 10 years. But most important, it really does improve the productivity and experience for the clinician because it's all hands off for the primary care physician. That test actually goes then to, the image goes to a retinal specialist, and the report is sent back through the cloud back into the electronic health record of the primary care physician, so they see that. But they also get paid for doing that test. So they're basically being paid to really accomplish the triple aim or quadruple aim in this instance. So physicians feel like they're actually getting the stuff done that they couldn't get done before. Their patients are getting the treatment and preventive tests they need, and they're actually getting compensated. So you're kind of freeing time up by enabling them to be compensated for that.
It's a really helpful example, and I'm just noticing the time, so I might turn to some of the questions that the audience has been asking, which are great questions, and Punit, I might turn this to you. How do you actually create we know that burnout's an issue, and we want to get these products out in the market. How do you actually convince people about the return on investment and the reasons to buy this? And David, it might be helpful also to hear you as well as a purchaser, how you evaluate these technologies and decide how to make a purchase.
Yeah, I mean, my take on this is even before ROI comes something slightly deeper, permission. Do you get the permission from a clinician to exist in their exam room or exist in their workflow? And if you have that permission, then you can put a product in place, then you can measure how much time you save, you can measure how much revenue you made, you can do all of those things. When you start with ROI, you actually end up building products that optimize that and don't get permission. And then intrinsically, regardless of what you build and how many C-level folks want to force the product onto their clinicians, it's just never going to get that traction. And so I'll answer your question directly, but my first reaction is there are multiple ways to think about how to take what we call AI and put it into health systems. One is do these broad-based engagements with large health systems, take their entire EMR, underlying EMR and all the things there and try to figure out how to integrate with all of these things. And 5 years later, after you spent many, many hundred millions of dollars, maybe, just maybe you'll get there. The other way to do, which is like a small, scrappy startup, my preferred way at this point, is to find a tiny sliver, very, very small sliver of problem, figure out a way to sit on top of these EMRs in a way that don't disturb their workflow and all the data that's actually sitting on top of it, and then spend most of the energy of the team in making the doctor happy. And so every pixel in my company is in the service of the user, and the user is actually the doctor. If you can do that, if you can solve that problem, ways to solve that problem using real machine learning is, and Peter's actually mentioned some of these things, use deep learning to figure out that when doctors actually make mistakes or this transcription software makes mistakes, it can over time self-correct itself. Absolutely something that Nuance actually has done a pretty good job of. Look at the kind of notes and documentation that doctors have been creating over time and start figuring out patterns. How exactly are they using and what is the profile of the patient for whom this particular note was created? And using that, start creating nuances that can be later on used for follow-up in future patients. Start actually applying real medical ontology and not just do speech to text, but what did you really say? What was the meaning? I said I had a normal physical exam. Just converting into speech is one thing, or text is one thing. The other thing is to understanding it is a physical exam. For this doctor, this is how a physical exam looks like. When they say it's a normal physical exam, this is what basically they mean. So if you do those things, you delight doctors. If you delight doctors and they start using your product, for some of the reasons and data that I think market leaders like Nuance already have seen, you actually dramatically improve efficiency. You improve efficiency, either doctors can go back home early or they can see more patients. In either case, they're probably happier seeing patients than doing documentation. So you get the ROI that you need to get.
So Punit, you just touched on a second question that came through, which is how do you build trust in these algorithms, delight the clinician so that it builds adoption. So David, I was wondering if you could build on the first question, which I asked around how do you actually make the argument to purchase these and convince adoption within the system, but also the trust question, because I think those two are linked.
They're interrelated.
Yeah.
Thank you, Sree. And so to speak to the ROI, there's actually two types of ROI we have to consider. One is, of course, the tangible ROI or financial ROI. And it's there, but it's in the form of, are we seeing increased productivity from our physicians, our clinicians, in terms of patients seen per session, patient throughput in the hospital, and so on. But payment models are changing. You've heard that from Administrator Verma earlier, working with the payers and global and value-based purchasing models. It's changing that calculation. So other productivity-related ROI come down to, are you seeing more new patients? Are you seeing a higher acuity of patients? And are you documenting at a level that justifies the type of coding that you're doing based on the acuity of the patients that you're seeing? Now, those are kind of the financial ROI, and if we do AI correctly, what we do is we improve the ways that our physicians can more efficiently see those types of patients. But then I would say, and where my heart is in the intangible ROIs, which really are we allowing our physicians more time in front of the patient? Are we allowing physicians to finish their sessions so that they go home and they can see their kids' soccer games at night? Are we allowing physicians time to be refreshed so that they are on target, they're actually thinking about the patient when they're in the exam room, not thinking about the administrative burden and the things that they need to do? So the selling point that we've been making to our CFOs, to our CEO at Mass General, at partners and our partner sites, is really to start by looking at those intangibles, start by looking at metrics that prove that our physicians, our clinicians are happier, they're more personally productive, they're more fulfilled, and you're avoiding the burnout rates and the loss of physicians to the system in that way. But Sree, you're also talking about the culture change. And it's ironic because we've seen this with voice recognition, we've seen it with scribes, virtual scribes, the centralization and delegation of processes, central ordering, central scheduling. Ironically, our physicians are probably the hardest ones to convince to take on the new tech. And that's where, for all of us in the room, this is our challenge, because clinicians tend to be extremely conservative in their approach. They are trained in a certain way, an apprentice model. They learned to do their work by watching the older physicians that trained before them. And so it is really tough to get them to change their workflows, even when the workflows are painful, and even when the outcomes don't make sense, or even when it's painful personally to provide the care. And so I think the incremental steps include doing essentially experimental implementations where you simulate the AI-driven workflows. As an example, when we first rolled out virtual scribes, the key impediment from our physician's perspective was, well, we don't want to record this interaction. Well, you're going to see the same thing when we put in digital voice assistants. You're going to see the same thing when you put any sort of recording device in the exam room. But it took doing this process with human-driven virtual scribe teams over and over again to help our clinicians experience that, boy, this is safe, this is efficient, and I'm getting more face-to-face time with the patients. And by the way, my patients love it. They come back to us and they say, wow, for the first time, I'm seeing my patient's eyeballs instead of the back of a laptop computer. So that positive experience starts to create the swell of demand for implementation of these technologies and so on. So it's very much like, Punit, as you said, show the delight, show the things that improve the process today. And I'm glad that Peter brought up Atul Gawande's thoughts. Think about the entire arc of the workflow, not just focusing on the tool of artificial intelligence or the visualization tool itself or the reporting tools themselves, but think about the entire arc of how are you going to collect that data, analyze it, visualize it, execute on it as a package. So I think the final thought, Sree, is we talk about in the age of convoluted neural networks needing to have understandable AI. I would say we need to focus on usable AI and AI that makes sense in the whole workflow of the clinician.
That's very helpful. And many of the technologies that you described are changing the clinician workflow, but are visible to a certain extent to the patient. I was wondering for the panel, how much have patients commented or reacted to these new technologies entering the clinical workflow? Do they recognize them and see them as value added, or are they seeing them as intrusive to the doctor-patient relationship, or somewhere in between?
Yeah, that's a great question. We've actually done a bunch of work. It's interesting because as you would expect, most of that decision is made by the provider. As you all know, providers have very different habits of when they complete the notes. Some do it with the patient, many do it between patients, some do it at the end of the day. So it's all over the map. But the data that we've seen from providers that have done it with the patient has actually been stunningly positive if the provider makes that decision. Because a couple things. One is they tend to spend more time with the patient. It just saves time. Two is it gives the impression that the provider is more technologically advanced. And I have to say, over the last 4 or 5 years, the introduction of Alexa at home has radically changed the expectation of many consumers when they go to the physician. If I can ask to add a thing to my shopping list or play music, why is someone over there doing this? And so we see this big arc. It's not everybody, right? I mean, there's different opinions with the patients, and certainly certain providers are for it and against it. But the data that we've seen is that there are actually significant improvements in patient experience. If you look at some of the other studies about patient dissatisfaction, which again, all of the providers in the room know, the biggest dissatisfier is I can't get an appointment when I want. I don't have enough time with the physicians. And they keep asking me the same bloody questions over and over again. Right, so if any ones that attack those issues really do make a difference. And so it's a small step, I think, but we've seen very positive reactions from the data. Again, I think it may be a biased sample because it's the providers that are willing to do it, but so far it looks very positive.
Yeah, I can speak to the Cox Health example because we've got some anecdotes from them. And first of all, you have to realize that for patients in this case, it's invisible. AI is invisible to them. They just see it as an opportunity to get a test done that they've been nagged to get for years, and they finally are able to get it done without the cost and inconvenience and dilated exams and so forth. And so, and the other report that we've gotten from them is they've said they feel like they're much more in charge of their own health. They can, it's easier to get that exam done because they know they need to get it done.
Yeah, I mean, I have two reactions. One, I agree with Peter. I think, in our initial trials, we are seeing that when doctors just use a voice technology, they can casually use it while they're talking to the patient and say certain things, or they can say, okay, so let me summarize. Here's the plan. We're going to do A, B, C, D, E. And that act of summarization and telling the voice assistant to do something gives the patient a lot of comfort that this is actually A, being taken care of, not just going to slip through the cracks. B, they also get reiteration of the fact of things they need to do. So I think there is a consumer angle to why this actually works very well in the workflow if done right. So that's one point. Second is, I think there's a technology arc we should consider here. You have to tread very carefully in a healthcare setting, in a clinician setting. Initially, you may have something that is, very directive, but it's, the doctor saying something to the voice technology or to the AI. Then you may have something where the AI is actually starting to nudge back. Have you considered this? Maybe this is an issue. Maybe this is something you need to think about. Then you get to a place where you have diarization. So you have two different people talking, the doctor and the patient, and you have the ability now to take that conversation and make some sense out of it. I think there's a natural arc where then there's third-party people, caretakers, caregivers, nurses, social workers, the patient also outside of the context. Voice, in my opinion, is the new mobile. 2007, we were talking about mobile technology. In 10 years, voice will be as pervasive as mobile, and all of these constituencies are going to be served by that.
Great, thank you so much. And I know we started out with some sobering facts, but I'm walking away from this panel feeling with hope, full of hope that we do see technology solutions to addressing clinician burnout and improving the patient-physician relationship. So thank you to the panel for sharing your expertise.